Well, hi, folks. Welcome to our Medicaid and CHIP disenrollment webinar presented by members of our legal corps. We're just going to give a couple of minutes, as often people will be transitioning from other events to this. So we'll get started shortly. Thank you all.
Thank you. We have plenty of time. So we left plenty of time for Q&A. So thank you. Wait for folks to keep coming on.
Okay, folks, as people transition on, whether it's a small and mighty group or a larger number of people that jump on later, not of concern. This is incredible information. If I understand correctly, Damien, this is being and will be recorded, so it would certainly be available to folks if they were unable to cut loose from other events to join this today. For those that did join us, we welcome you and thank you for coming on. My name is Kevin McCulley. I serve as the Chief Operating Officer for the Pediatric Pandemic Network. I won't take up too much of your time other than to say we're very glad to have this group ready and active in the PPN. Although we may not see a lot of the work of the legal corps on a day-to-day basis, the work that they do is actually foundational to much of the disaster preparedness and response work in which we're engaged every day. I think without any further ado, Damien, I will turn it over to you to go ahead and introduce the deck, introduce our speakers, and thank you all again for those that joined. Thank you.
Thank you, Kevin. And once again, welcome everybody to our Impacts of Medicaid on CHIP Disenrollment of U.S. Children on Routine Medical Care and All Hazards Readiness webinar. Before we get into it, just a couple of housekeeping items. Once again, this is a webinar, not our standard traditional Zoom. As such, the host, co-hosts, and panelists are the ones that can actually engage in the audio and video presentations. Controls for this meeting, we ask any questions and interaction with the presenters be submitted through the question and answer function of the webinar. The chat, the polls, the hands raised, and other reactions will not be monitored. So once again, interaction with presenters, please submit your questions through the question and answer feature. As mentioned a minute ago, we are recording, and this recording will be accessible through the PPN homepage within 2 business days. The slides presented during this webinar will not be distributed or shared outside of this webinar. If you have a great interest in viewing those slides, they can be reviewed in the recording webinar when it becomes available. The presenters have no financial disclosure or conflicts of interest with material in this presentation. And of course, our PPN funding statement, the network is supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, as part of cooperative agreements with 0% finance with non-government funds, The content presented here is that of the authors and does not necessarily represent the official views of nor endorsement by HRSA, Health and Human Services, or the U.S. government. For additional information, of course, you're invited to visit the HRSA homepage at hrsa.gov. And our first presentation today, of course, is going to come from Dr. Marie Lozam, Professor Emerita of Emergency Medicine and Pediatrics at the University of Michigan. Dr. Lozan is both an SME and domain leader for the Pediatric Pandemic Network, as well as a co-investigator and domain leader for the Region 5 for Kids Pediatric Center of Excellence. Dr. Lozan?
Thank you, Damien. I am going to be the presenter of the very brief overview of what the heck happened, and then we will dive into the expert legal review of what has gone on during the Medicaid unwinding and its impact, especially on areas of access and equitable care for children. I'm going to start by thanking our colleagues. Next slide, please, Damien. I'm very grateful to the PPN operational leaders, Kevin, our communications group, Damien Seawick, one of our excellent project managers who helped put this together, Professor James G. Hodge, who partnered with me on this webinar. He is the director of the ASU Center for Public Health Law and Policy at Arizona State University. You'll really want to listen carefully to the analysis of all the legal issues going on. And I also want to thank the Pediatric Pandemic Network colleagues. Those of us who are in the PPN know the dozens and dozens and dozens of folks that are working constantly to improve care for children in a disaster or pandemic. So thank you for that. Thank you. Next slide, please. Many of us remember that fateful day, January 31, 2020. I can't unremember the national public health emergency being declared. As that public health emergency was declared in response to the COVID crisis, there was an ability for children to stay on Medicaid without the need for automatic annual re-enrollment. And this ended when the public health emergency stood down last spring, not this past spring, but the spring before in 2023. This graphic is from the American Academy of Pediatrics. You'll see it a little bit later, and it shows in both proportion and in actual terms the number of kids that were on Medicaid. About 46% of kids in the United States were on Medicaid when the public health emergency was called. By the time it was stood down, the Medicaid rolls for children had reached a peak of about 56% of kids, going from about 35 million to about 42 million. And as you can see by that red line, it starts to the downward trend of kids falling off the Medicaid rolls, the unwinding process, and you'll hear that term over and over, unwinding of the public health emergencies, Medicaid waivers or processes that allowed kids to stay enrolled continuously. Kids have then fallen off the rolls since then. You'll see this figure again. This figure represents data ending in December of 2023, calendar year 2023. Next slide, please. This was not a surprise to us. Many advocates and folks that focus on the care of children warned about this unwinding process and the dates. And it wasn't as if the day that the public health emergency ended, that threw the kids off the rolls. There was a process in each state to reconsider, to look at re-enrollment processes, and they had about 14 months to complete that. Professor Hodge will discuss waivers and other things, but what I want to make clear is those of us in the business of caring for children, I'll give an example, the American Academy of Pediatrics, of which I'm a proud fellow, produced many resources for families and providers in preparation. The Kaiser Family Foundation, the Georgetown Center, the Assistant Secretary for Planning and Enrollment, put out position papers and briefs saying, we're very worried that 15 million folks could lose their coverage, and as many as 5+ million kids. And we're very worried that these losses will be not because they've lost eligibility, they won't have changed the state of their eligibility, but because of administrative reasons. And that we worry about a disproportionate impact on children and folks of color. So this was not going to be necessarily a surprise. But when one is living through a worldwide pandemic, one has precarious, maybe mail services, or one is not necessarily staying at the same house. Forms get lost. Mail is lost in the mail. And kids, it was very, very, very concerning that kids would fall off the rolls and lose their coverage. Next slide, please. The AAP advocated vigorously, starting well before the end of the public health emergency, because we knew when that was going to be, and they knew that the unwinding would occur. Pediatricians advocated vigorously, and the AAP created videos in multiple languages to preserve Medicaid and CHIP coverage for their patients. Next slide, please. The AAP produced unwinding guidance. It produced template letters for the practices to send to their patients, flyers for the office, multiple language flyers for each state, what to do for families, what to do for practices. Next slide, please. Despite the advocacy, despite the reverberations through all the, what I would call those of us who care for kids OSPHERE, we still are concerned, and the data from CMS would suggest that at least 4 million children are missing from the state's Medicaid rolls. You'll remember this figure that I showed earlier. This is from the AAP News in May. The PHE declaration, et cetera, and that sort of loss of kids off the Medicaid rolls toward the end of the calendar year. James will have a little more recent data, and as of June, this data is still holding that about 4 million kids are missing. Are they non-eligible? It's thought that that's probably not the case, that administrative issues are probably causing an impact. The AAP News last month devoted a significant amount of pages to discussing this problem. And even though the AAP, the Kaiser Family Foundation, Children's Hospital Association worked assiduously to ensure continuous coverage for kids, it didn't occur in every case. Next slide, please. This is a heat map from that same article using CMS data, and you'll see that state by state, there's been a differential reduction of the enrollment of kids. You'll see that between April and December of 2023, just in that short time, not even a full calendar year, some states had a pretty drastic reduction of the percentage of kids in their state that were covered by Medicaid. I'll note that Arizona just didn't have data available. But for those states where data was available, some states experienced only a small reduction in kids on the Medicaid rolls. Other states, pretty dramatic, 1 to 4 or 1 to 5 to 1 to out of 4 kids, 26% in some cases, 22% in Texas. And these are kids I'm talking about. This is not all Medicaid enrollees. But those kinds of differential losses across the states are just very concerning. And there's not, I can't tell you exactly if the kids in Florida and Texas, Arizona, California, if the eligibility changed. I just am showing you the data from CMS with dramatic changes across the nation. Next slide, please. So what does this mean? I think this is, I won't state the obvious. Everyday care is impacted. About half the kids in our country are covered by Medicaid or state CHIPs, Children's Health Insurance Programs. And with this disenrollment, there are clinics that are set up to make sure that underserved communities and kids with a high proportion of Medicaid coverage are seen in in that community. And they're seeing patients lost from their clinic rosters, kids that were getting their primary care gone off their roster because they've lost their coverage. And it's extremely concerning that the AAP notes that surgeries are being postponed. Now you might say, well, of course, if the child came in from a trauma and they needed to go to the OR immediately, of course, that wouldn't matter that they were not covered. But an elective surgery that a child needs, for example, to correct scoliosis surgery, often those are saved for the summer month when children are not in school. And those are big surgeries. And imagine waiting a year to get on the schedule to have that surgery finally performed by a pediatric orthopedist, and you get it delayed because of your Medicaid issues. What if you can't get your EpiPen, your child's insulin is at risk? I can't imagine the devastation of waiting for a specialty appointment, a cardiologist, an allergist, whoever I was hoping my child could see, and then that gets canceled due to coverage. And as an emergency pediatrician, I see many people who are uninsured in the emergency department. Of course, I'm happy to see them, and federal law, EMTALA, requires emergency departments to see any and all comers. But this is not great primary care for children. Getting their sports physical, or make sure they're growing well, or getting their full complement of health maintenance is not a great place to get that in the emergency department. And you may say, well, of course, there's children's hospital social work departments or business continuity departments that would assist families. Yes, well, there are, and there are in the emergency department too, but these can be clunky and maybe not available in the middle of the night when a child is ill to get an authorization for assistance with a medication that a child needs to go home with. So this is a truly real problem for many families. And should we have a winter virus season like we had in 2022 to 2023, God forbid, or another pandemic, I worry that these kids will remain still have difficulty accessing care. I truly hope that we think of making sure kids are covered as a preparedness activity, and that's what we are working on and thinking about in the course of this webinar. Next slide, please. I would ask if you have any questions or want to get live links to some of these unwinding data or resources. Children's Hospital Association has some great concatenation and gathering of a lot of information about the unwinding. And many of the links have state-by-state real-time trackers to see what's going on in your state for your family. If you want to check out their website, Children's Hospital Association serves not just children's freestanding hospitals, but also children's hospitals within larger hospitals, and really wants to make sure that kids get covered so they can get hospital and healthcare resources. So that's my pitch to understand the impact of millions of kids in this country on the unwinding of this. But for a much more a deep analysis into the legal and ethical aspects of this, I'm going to turn it over to my colleague. Professor James Hodgin is an esteemed colleague. He works both with RAPM, the Center of Excellence on the western side of the United States, and I've known him for years through that. But he is also the Peter Kiewit Foundation Professor of Law at Arizona State and heads their Center for Health Law and Policy. And he is going to present the deeper legal analysis of this, and including some case law that is currently not even, it's pending at this point. We don't even have some things decided yet. And he'll take us through that. And I turn it over to him. And thank you very much, Professor Hodge.
Great, Marie. Thank you. And you set us up perfectly for what we're really about to launch into in regards to this part of the discussion. You know, COVID-19 may be in our rearview mirror for purposes as far as active cases and such, but the sheer reality is we're staring right ahead at an epidemic of access to care for kids. And it's all caused by federal law, both the infusion of additional opportunities for Medicaid coverage, that is, and CHIPS coverage, as well as the rescission of that coverage post-COVID. And so with that said, as Marie noted and set us up so perfectly with some unbelievable and incredible data, just showing the immensity of the problem in relation to what we're experiencing nationally right now with kids' access to care, either through their parents or directly through CHIPS. You know, this disenrollment storyline of what she's laid out there perfectly, I'll try to continue a little bit and give you some of the backdrop briefly, but also set us up perfectly for how to absorb the public health and social repercussions of disenrollment happening still across the United States, legal, ethical, and political issues that we'll discuss briefly, CMS-related approaches to disenrollment, what is how CMS responded to some of what they're watching and sensing across the United States, and some of those most compelling data that you saw Marie issue about states that have lost literally like 1/4 of the kids in regards to pre and post-COVID. Active litigation issues, I'll bring up 2 predominant cases that will give you a strong sense of where we stand on litigation, some of which are reflective of other states as well, and questions and comments. So let me mention again, as Damien noted at the start of this webinar, listen, if you have questions, go to the Q&A, put your question in there. I think Damien and or Kevin is monitoring that. Maria and I look forward in just a few moments to taking any questions, comments, and honestly observations of what you're seeing and experiencing across the United States too. Okay, without further ado, let's just make sure we're all on the same page legally as to what just happened over the last 3 to 4 years. Everybody knows what COVID caused in the United States. The grandest illustration of basically uninsured Americans swelling to the tune of exponential growth due to business closures, unemployment rates at rates we had never seen before, pre-pandemic, obviously. To be sure, that led Congress and pursuant to the Trump administration to pass the Family First Coronavirus Recovery Act in March 2020. Here's what states, all states, agreed to as part of that. And this is the enrollment portion of what we're actually discussing, is what led to multiple millions of persons keeping and or enrolling in Medicaid during the course of the pandemic. Basically, to receive higher Medicaid contributions from CMS, every state agreed to allow existing beneficiaries to retain that coverage, essentially ending that sort of churning practice that every state goes through to figure out each year on whatever annualized basis of which person should be knocked off of the Medicaid rolls or otherwise. We're going to stop that practice in its tracks, and we're going to take on new Medicaid beneficiaries. Every state agreed to this, and every state enrolled lots of additional new Medicaid beneficiaries as a result of that. In fact, what you see in this chart that's really nice and helpful, supplementing what you saw from Marie just a few moments ago, is just the significant amount of persons across all the states that were actually granted Medicaid access from that period of time of February 2020 to December 2022, for example. Just massive growth of numbers of persons by percentages here you're seeing enrolling in and gaining access to Medicaid because of the conditions of what the pandemic caused. Look at some of the diversity there. You're seeing even, up towards 15 to 20% in states like New Mexico and Connecticut, all the way up to 80% in some jurisdictions like Oklahoma and Nebraska. Fascinating stats, and all reflective of the sheer essence of what you're seeing with Medicaid growth over that 3-year period. 32% increase over that short period of time. If federal law brought that to our attention and the opportunity for enrollment, it also is substantively involved in disenrollment, or as Marie notes, what we call unwinding. The Consolidated Appropriations Act basically brought the end to that continuous enrollment allowance requirement. And consequently, as of April 3rd of 2023, you started states, some vigorously looking to do what they could to disenroll persons from Medicaid, knowing that at that point in time, they weren't going to get that same sort of CMS contribution for all those persons, in some cases, hundreds of thousands per state, that were enrolled during the throes of the emergency. And as a consequence, disenrollment procedures commenced in and around, about a year and a couple months ago. They continue to this day. There are 2 premier approaches to how these disenrollment efforts are ongoing. And what's so fascinating about these legally is just what sort of wires they trip along the way. The 2 types of which you see, and it's happening across virtually every state, are what we call the procedural disenrollment or the eligibility disenrollment. Procedurals when, hey, people just flat out do not do or take the proper procedures to actually re-enroll or to continue their enrollment within Medicaid or CHIPS or what have you. If they don't do that successfully, they can be disenrolled from Medicaid. Eligibility is, basically where you do not any longer qualify for a specific benefit because you maybe have a higher income or other specific eligibility measures are not met. Now, the compelling statistics you're seeing on screen there that's worth noting right now, because this has proven true over the last couple of years, 75% of persons who have lost Medicaid over this last period of time, millions of Americans, have lost it because of procedural failures or requirements. Only about a quarter of persons have lost them due to eligibility failures. Now that's compelling because states, as we're going to see throughout the course of what we're about to document here, they're in control of these procedural mechanisms. They can shape those, dictate those. They can change them within allowances allowed pursuant to CMS regulations and federal law. But some states are choosing to actually make it more difficult to continue to retain Medicaid, even if you are eligible. So consequently, what you're starting to see show up in the press is the types of stories that we've been watching and monitoring since the specific effort came about. People who lost their Medicaid, not because of some eligibility issue, but because they couldn't master the procedures or because states made it difficult for them to master those procedures. And that 75% of persons losing Medicaid eligibility post-COVID or post, when we've started the disenrollment process is unbelievable in relation to the overall impact that this has, particularly on children. The disenrollment stats, as you're seeing to date, as of June 4th, thanks to the Kaiser Family Foundation, really are quite compelling. You're seeing total CHIP enrollment, Medicaid enrollment of 94 million as of March 2023. 24% of those 22 million people disenrolled now. We have renewals remaining for another 22 million persons, literally still in the process of potentially being disenrolled. This is tens of millions of Americans unwinding their Medicaid-related benefits, all guaranteed during the pandemic, now being rescinded and taken back post-pandemic. It's a fascinating series of developments, and states are in control of it in so many different facets. There are pros and cons to disenrollment and how states have actually gone about this. Look at on the positive side what states have done to actually make sure disenrollment doesn't overly impact their Medicaid populations. Some, for example, have aggressively relied on ex parte auto renewals. What that essentially means is, if you don't know, is, hey, listen, we're going to actually use every available financial or other statistic we can already automatically populate about you, the Medicaid beneficiary, to make sure that you continue to apply, you continue to get the benefit of Medicaid coverage. We're not going to require you to go through a lot of paperwork. We're not going to do all those things. We're going to auto-populate your Medicaid renewal based on the best data that we've got. That's good affirmative practice, and some states are doing that quite extensively. Some states are also extending enrollment periods. They're not dwindling it down to the shortest period possible to retain Medicaid coverage. They're giving you longer periods of time, 12 to 16 months to accomplish that. Some are setting considerably lower administrative barriers. They're reducing the frequency, the duration of which you have to actually undergo those eligibility determinations. All of these bullets that you're seeing on the left side of your screen in green make a critical difference about who actually retains their coverage and who doesn't. Auto enrollment at the lowest possible cost, especially for $0 plans. We're going to automatically, like in California, put you in our lowest cost plan possible so you can retain that coverage. You can actually get the benefit of that coverage. We're going to provide financial assistance, help you find or secure marketplace plans if you don't retain that coverage. Rhode Island's taken that step. You may not be on Medicaid any longer, but we found for you a federally or state-assisted subsidized plan via the marketplace. And some are actually doing really strong targeted outreach for groups that are at greatest risk of churning. If some states have identified a particular subpopulation at great risk, they're doing the outreach necessary to make sure that if they're going to be disenrolled, it's not because of a procedural issue. Look at the other side of the screen. This is what some states are up to. This is what CMS is watching so carefully. Now, some states flat out still continue to fail to expand Medicaid, and that's a problem. This is all back to the Affordable Care Act. This is about Medicaid expansion. This is about some very large population states that still don't do that, and that's obviously problematic because Medicaid expansion would clearly enroll multiple millions more kids and families along the way. But beyond that, they're actually taking active efforts in some jurisdictions, literally out to disenroll as many persons as possible. Now, just to be sure, this is getting litigated, and you'll see a little bit of what we've got in mind in relation to that in a couple states in just a moment. Some don't staff their call centers very well. People sitting literally for hours trying to actually get through for promised benefits and coverage or trying to meet their procedural requirements. Pretty tough to do that unless you have hours on end to actually deal with their poorly staffed centers. Long wait times, insufficient translation of renewal materials, These things are not consistent with CMS practice, of course, but they're still happening in some jurisdictions. Inadequate disenrollment notices. Florida's gotten caught up on that, literally not providing sufficient notice as required by federal law under CMS regulations. Unclear appeal processes underway, sometimes no appeal process. We've seen that challenged in Tennessee. You'll get that in a moment. And electronic access barriers, errant termination letters. We're seeing it all. All of these measures across some jurisdictions are happening and thus obfuscating and complicating significantly the capacity to keep people enrolled on Medicaid that they're eligible for. That's the crux here. That's what's so problematic. These people are entitled to Medicaid assurances. They just can't get through the procedural elements to keep it. And as a result, the disenrollment declines are pronounced. And some of what you're seeing here, states like Utah with in excess of 35% of persons who've gotten enrolled now off of Medicaid. Of course, this over a period of time, as Marie did a great job showing us with a sort of US map approach, really profound data. This is just becoming epidemic, especially for kids. Getting access to coverage again that federal law says, and states that have agreed to it have said they should have coverage. You know, the consequences of this can't be underappreciated any more than what we can say in regards to what Kaiser Family Foundation has tracked so well. And that is, of all of these Americans that are disenrolled, at some point, even if it's temporary, 65% of those millions of Americans are experiencing some period of uninsurance. So that child or otherwise who needs access to that asthma medication, or that person who's on diabetes and facing, you know, specific regular anticipated needs for how to get specific medical treatment, they're losing their insurance for some period of time. The catastrophe in relation to that for medical purposes, obviously Maria's emphasized so neatly and so well. But let's just take stock of that, that even if you regain that coverage, even if you get through that process, which some states are working very hard to make sure you don't, you're at some juncture, most of them, losing insurance coverage during the throes of that. It produces its own physical and mental health consequences. And that's a little bit of what we'll discuss here now. The major impacts you're seeing on minorities, on at-risk groups, particularly dual eligibles, specifically having trouble retaining Medicaid coverage, and kids as well. You know, the research that's really starting to come out of this is just about as invidious as you can imagine in relation to the impact on particular racial and ethnic groups. Black and Hispanic adults, particularly more likely than white adults, to be disenrolled for procedural reasons. This is a statement that's resonating out of what we're seeing. New York Times is reporting on it. CMS is tracking it carefully. And the reality is that's just a finding. It's just a happening. It's just like during the pandemic. Persons who are great at risk, experiencing some of the worst harms in disenrollment strategies, same basic procedures. This is unacceptable and something CMS is addressing, but to be sure, we'll see a little more on that as well in just a second. The state variations in disenrollment are impacting these discrepancies. There's no question about that. All the things I showed you on that sort of positive and pro and con slide, wow, it's really playing out. And while some error could have occurred due to self-reported data, as we're seeing, some states are not actually required to report race-related data along with decisions made. The basic elements of what we're seeing reveal consistently greater impacts on persons of color, persons of specific different minority groups. You know, this slide's kind of interesting. If you look on the left side of the screen, it's not bad. To the degree to which percentage of persons were asked to submit, you know, as part of Medicaid renewal processes, proof of income or financial assets, actually, white Americans, just as many as Hispanic or Black Americans, required to submit to that, somewhere in the roughly nature of 75% or more. That's not bad in the sense of the equity side of it, but look on the right side of your screen. Those who actually are asked to prove residency, eligibility requirement, for example, 71% of the Black population, 60% of Hispanic, but only 42% of white populations. There's no other way to explain that other than equitable misapplication and or administration of these disenrollment procedures at stake. Is there a silver lining here? Is there something we should actually be feeling okay about in relation to what HHS reported just earlier this month? For they found in their recent report that over the last decade, thanks in large part to the Affordable Care Act, the uninsured rate among Black and Hispanic populations is actually cut in half. That's a good development. And this is the sort of thing that you can look at positively as HHS properly does through Secretary Becerra and otherwise. But the sheer reality is when you're disenrolling persons in a way that most impacts persons who are at greatest need, That's a trend that we've got to reverse for, notwithstanding these very good sort of decadal provisions that we're seeing post-ACA. Basically, the impact, as Marie showed us and talked about very briefly in relation to provision of care, this is showing up. As Medicaid shrinks, as the New York Times reports, the poor are just trying to survive. In the clinics, like in my hometown of Louisville, Kentucky, although I sit here in Phoenix, Arizona now, Family Health Center in Louisville, Kentucky, reporting systematically because of the Medicaid disenrollment related issues, they're having declines in patient populations that can actually pay for the type of care that they're providing. That 6% decline they've registered over a very short period of time, just over a year, is literally leading to millions of dollars of lost revenue for these family health centers, already bootstrapped in relation to their costs, just trying to make it within the provision of care for people most in need. So you're seeing for kids and persons, supporting those children, the opportunity pursuant to disenrollment to just continue basic access to care so greatly challenged. And the family health centers trying to provide it across the nation, challenged as well. One of the things that recently my colleagues at our ASU Center for Public Health Law and Policy did, for which this ties in so neatly to what we're here to discuss briefly, is what we were really looking at extensively in some of the very systematic anti-equity legislation that you're seeing across the United States in virtually every state. No matter whether conservative driven or liberal, we're seeing this type of legislation showing up extensively. And the whole provision of it relates to the types of anti-equity measures that states are willing to consider post-COVID in regards to bringing things back to norms that maybe presented themselves prior to the pandemic. But I'll tell you one trend that's starting to show up and is reflective of what you're seeing as problematic for disenrolling persons from Medicaid is the anti-gender-based care related trends. So these legislative packages existing across a lot of different states basically lend to some very significant trends. Standards of care have been dictated in ways that have denied care on gender-based related fronts. We provide specific informed consent in ways that are very profoundly different, especially for minors involved in this specific care. We're requiring reporting, which leads to privacy-related issues. All of these are very interesting trends, well documented in that piece of scholarship I showed and have presented on specific other occasions. But it's the fourth element you're seeing in your bottom right corner that's most interesting. States flat out prohibiting public funds from being used for gender-based care, notwithstanding doctors literally suggesting what sort of care is essential. The same sort of Medicaid state-funded dollars that might have been there to provide this care, now disenrolling populations from those particular fronts and even disallowing the use of that specific measure for these types of populations. That's what's getting interesting. And even as the Biden administration has worked already to issue federal guidance, establishing or sort of assuring that access particular to care, and Republicans introducing measures, fighting over these specific issues, politically trying to come to terms with where everybody stands, courts intervening and already putting a null on the existing Biden administration measures. These things get dicey fast against this backdrop of disenrolling millions of kids and their parents from Medicaid that might have provided some level of coverage, notwithstanding these anti-equity related trends as well. CMS is all over these specific issues, and to be sure, the Biden administration and CMS has worked hard to address these in specific jurisdictions. They have issued multiple waivers to decrease the load on states while redetermining eligibility. These waiver categories include some of the very same themes we've talked about just earlier. Themes related to ex parte renewal rates, allowing greater access, greater waivers, allowing states to utilize that other data from other financial sources to just guarantee renewal. Reducing procedural terminations, updating contact information, waivers to allow for procedural reinstatement of eligible individuals faster and more to the point, and other particular measures involving fair hearings and premium resumption delays and all sorts of other fronts. They've issued nearly 400, probably past 400 waivers as of the end of May of this specific year. At least every state's enjoyed or at least benefited from one of these waivers being approved, all designed to tamp down the impact of Medicaid disenrollment. The specific guidance they've given related to children's enrollment, CMS, in this specific slide, in which the agency has literally laid out some of the measures they've taken, you're seeing the type of strategies and efforts CMS has undergone to try to, really stymie this specific trend. They're allowing every possible strategy under the full gamut of federal law to actually provide that sort of improved rates of auto renewal, the sort of ex parte allowance you're seeing in that first bullet, They're ensuring that kids' eligibility is being considered separately from families' eligibility, trying to ensure that kids get access to their CHIP or otherwise kids found ineligible. They're using data in the auto renewal process to try to make that determination as easy as possible pursuant to those waivers. They're removing barriers to enrolling kids in CHIP, fees, premiums, waiting periods. CMS is up for that, and they're seeking states that are willing to impose or at least allow for that. Other measures also in place, and of course, CMS recommending, as we've seen before, states just expand Medicaid. Any remaining states, among those 10 or so that are still in that group, expand Medicaid. That will improve greatly youth coverage, especially for youth in that age 19 to 23 arena. If you think for a second that these states are getting away with these initiatives without litigation, think again. A couple of cases that I'll reveal for you now in Tennessee and in Florida give you a sense of how some entities, particularly like colleagues that we know at the National Health Law Program and other fronts, are seeking in this strong of a way via litigation to address these specific harms and damage for the purpose of the disenrollment. Some of these lawsuits came up during COVID and have just perpetuated throughout this disenrollment period, like this case AMC versus Smith in Tennessee. This is a class action lawsuit that originally filed during COVID. Why? Because we're seeing a lot of people stressing over how to keep their Medicaid related coverage, notwithstanding measures designed to keep that in place, as we've already discussed. But a class action now affirmed has basically, since those specific efforts, revealed and demonstrated a series of defective renewal notices and what they claim is a lack of proper notice at all, that one particular plaintiff describes at best as a bureaucratic maze imposed by TennCare, which is, of course, Tennessee's Medicare or Medicaid related provision. What you're seeing in relation to that, plaintiffs submitting new evidence of enrollees during this disenrollment period facing similar difficulties, all described in one as a sort of a gotcha game. States like Tennessee allegedly playing games with who should get eligibility, missing one step, failing to do one procedural requirement to the full satisfaction of TennCare, at least in some plaintiffs' allegations, leading to that gotcha. We got you. You tripped a wire and you lost your coverage. These measures have been challenged as due process related violations, Americans with Disabilities Act violations, because some of these cases do involve either kids or adults with disabilities. And Judge Crenshaw in federal court in Tennessee, at least giving initial consideration to the seriousness of what he's seeing within it. The due process concerns, just so you know, extend not just to federal constitutional law, but the sort of federal statutory provisions that come into play, requiring all the fair notice, all the fair hearings related to denying persons eligibility for state-based Medicaid coverage. It's fascinating. Do I have a decision for you on that case? No, it's moving slowly, as is the case that we're seeing in Florida. Again, post-COVID, right after we're seeing a class lawsuit being brought in the state of Florida through the National Health Law Program, Florida Health Justice Project, all again asserting similar things, due process related violations for procedural rescissions of Medicaid related coverage. Federal District Court Judge Marcia Morales Howard actually denied an immediate injunction to stop Florida in its tracks in relation to its Medicaid program. But even notwithstanding failing to provide that immediate injunction, she did later certify that class and denied dismissal of the claim entirely just about a couple months ago. So the case is going forward. And even after CMS guaranteed continuous CHIP enrollment for a 12-month period of time, as you saw them do earlier this year, when that took effect on January 1st, Florida, the state, sued CMS in another series of litigation to actually prevent its enforcement nationally pursuant to the Administrative Procedures Act. Again, claiming that CMS did not properly follow administrative procedures when it set this requirement for 12-month continuation coverage through CHIP. This type of litigation is ongoing. We don't have answers as to how this is going to turn out, but don't think for a second that these specific measures, particularly the procedural violations that are at least alleged, are not getting litigated in key jurisdictions. Now, you may say, okay, I got a good feel and good sense of what's going on, and I have a sense that maybe some of these measures might ultimately pan out, and we'll see some of the less aggressive practices being implemented by state, or more aggressive practices being implemented by states, curbed or tamped down. We've got a future perhaps better in relation to Medicaid enrollment as states learn their lessons and how to not disenroll and or unwind Medicaid provisions. And I'd like to agree with you that that's exactly what we can predict going forward, but it is very tough sledding when you consider what's still at stake in relation to the regulatory deference given to CMS in relation to what they can dictate or tell states. Because you see, what's happening before the Supreme Court as we speak is continued legal challenge expected any day. In fact, I'm really quite glad that the Supreme Court did not issue its decision in Loper Wright versus Raimondo and Relentless versus Department of Congress today, because it could have. Maybe tomorrow we'll see it. Why does this case come into play through the U.S. Supreme Court? What does it have relevance for what we're here to discuss briefly before we get to your questions and comments? This case is all about the amount of deference that federal courts must give to agency interpretations of congressional law when there are ambiguities. The type of deference that CMS and HHS and other agencies rely on to make determinations and then tell states, or at least guide states, in how they can administer Medicaid-related programs. It looks like the U.S. Supreme Court is prepared to upend the process through which that discretion tends to be given to agencies. What's otherwise known as Chevron deference is that deference that we give to administrative agencies at the federal level to interpret with some degree of discretion ambiguities in congressional law. So when there's an ambiguity, we're going to give some deference to federal agencies like CMS to interpret that correctly. That's up for consideration in these cases. And what a lot of prognosticators are saying is get ready for a new era of agency deference. And I mean less deference to agencies like CMS. As you see Solicitor General here, Elizabeth Preligar, note in her oral arguments, if Chevron's overturned, lower courts, even specific judges, they'll be empowered to actually make independent decisions about federal agencies' statutory authorities, including CMS, in ways that have not been seen in, as far as U.S. jurisprudence for decades. What we're really talking about here is, against the backdrop of everything we're trying to do to limit or tamp down aggressive disenrollment practices across states, even if CMS has specific guidance that it would like to offer to states based on its interpretations of what Congress has set out through the Social Security Act in implementing Medicaid, that's about to be seriously questioned as to the degree of deference CMS is going to be given potentially. I don't know what the forecast will be in relation to the outcome of this specific case. Again, prognosticators like me suggest get ready for agency deference to be upended. We're talking stormy seas ahead, because a lot of what's settled law in this specific arena could change drastically. Now, without further ado, thank you all so much. Thanks to my great colleagues at our Center for Public Health Law and Policy for their contributions to this part of the presentation. I'm going to stop sharing my screen now. We'll open it up to Q&A, and I'll turn it back over to Damien and to Marie.
Professor Hodge, I want to thank you so much for that. I want to restate the Chevron situation. What you are saying is, should Chevron deference be overturned, states can essentially tell CMS, we're going to do it our way. We don't bow to your suggestions around procedure and policy, et cetera. Please help us understand the loss of Chevron.
Yeah, here's what the loss of Chevron could mean. First of all, we don't know what the United States Supreme Court, which will have the final decision on this, we don't know what they'll replace it with. Some deference has to be provided. Agencies have got a job to do, and Congress, delegated that authority to them. But what deference? How much? What everybody's projecting is that the U.S. Supreme Court's going to tamp down that deference that's been traditional since 1984 via the Chevron case. And what you're going to be left with is agencies trying to actually ascertain congressional law against ambiguous statements. Now, when you see that sort of thing happen and their level of deference is sort of tamped down because of what we project through the Loper decision, Marie, the outcome of that will be states can challenge CMS on greater fronts, basically saying your interpretation of federal law on this is wrong. And consequentially, our approach to how we're doing Medicaid disenrollment, we're going to proceed as cause because we think that your determination is inaccurate. Congress would need to spell this out more carefully. And against the backdrop even of another federal doctrine via the U.S. Supreme Court called the Major Questions Doctrine, I think you're going to see challenges consistently against CMS's authority to set the stage for how these sort of disenrollment or frankly other Medicaid measures will be going down over the years ahead. It's a big concern and something we're watching very closely for those reasons, Marie.
Thank you for that. I'm extremely concerned that each state they'll become 50 fiefdoms. interpreting federal guidelines absolutely to their, in their own way. And that will be hard for kids if it's decided that disenrollment is allowable under certain situations. So more to follow on that. I'd like to open it up for more Q&A from others, should they be so inclined. We have a couple minutes. I did not see any active questions. Damien, any active questions that we need to put forth? Okay. Kevin, any comments from the PPN side of things? I think this is just some of the most troubling areas that will require advocacy for the child population. I mean, for the whole population, but certainly for the child population. Those of us who have young adults in our households, mine are well past age 23, but young adults graduating high school or entering those college years and who are still eligible for Medicaid, they are, it becomes very dicey to be able to be a young adult in this country and manage to get your own insurance. I know some states have good state health insurance options that you can become eligible to sign up for through the ACA, but if your state doesn't have those, you're kind of in a no man's land as you attempt to enter adulthood. But Kevin, any PPN commentary about this? This is not an area where we're educating on this. We're spreading the word on this. Everybody's in a different state of the union. Everybody's state is doing things differently, but we need to be aware, because if we should have another bad winter for children, if H5N1 should become a problem, I am very concerned about the ability for us to have people have their health care covered.
Well, thanks, Marie, James, Damien. I was devastated to see Utah topping that list of procedural disenrollments as I sit here in Salt Lake City. But beyond that, thinking of what James mentioned, is most of the PPN is built around disaster readiness and response. And as he noted, the everyday challenges that populations with barriers often face are exacerbated during disasters. And as you, James, Marie, and I have talked about, the potential reticence of elected leaders to declare disasters based on the experience during COVID could additionally have a substantial impact when or if things go sideways on us. That would just create additional barriers, or at least limit the opportunities to ensure healthcare during the worst of days. As far as just a brief bit of education, as you know, and as I noted at the beginning, legal core, small and mighty, certainly we've identified some critical topics that this group can come together and present webinars on. If there are other pressing topics that may be broadly of interest and applicable to our nationwide network, we certainly encourage you to reach out to either myself or to Damien, and we'll start talking about, as we go into our next budget period starting September 1, to perhaps another series of webinars. And I know, Marie, James, correct me if I'm wrong, I believe we will have one more, at least during this budget period. And that's digging in a bit more detail about the implication of items such as crisis standards of care, implementation and planning as it relates specifically to pediatric populations. So again,
yes, that's our plan. That's our plan. And we would like to introduce, we would like to bring in some experts on the ethical side of that, in addition to James's expertise on the legal side, to have that discussion. That'll be a very complicated discussion, and we are planning for that. I would like to acknowledge Pat Frost, active member of PPN, Regional Centers of Excellence, and the co-chair of the National Pediatric Disaster Coalition, who puts in the Q&A. Can you discuss the impact on children going out of state for services due to lack of access or disaster. And this is really an outstanding question because this was a real thing that happened during the triple-demic and during COVID when we had to say no over and over and over again for critical transports, and kids had to be flown out of state to get critical care in the triple-demic. James, could you comment a little bit on that? And then I'll also comment insofar as I'm able to. Go ahead, James.
Yeah, you know it, Marie. I mean, that's a great point by Pat on that front. Telehealth can only take us so far on these fronts. Telehealth was revolutionized during the pandemic, but no, when you're dealing with kids that need real care under specific circumstances, out-of-state care is greatly implicated when you don't have existing coverage within your home jurisdiction. States aren't required to cover Medicaid populations in other jurisdictions automatically. There are formulas and things through which those arrangements are made. They're not easy. They're complicated, specifically during pandemics. And to be sure, we saw that play out. It gets a lot easier when millions of kids have coverage already pursuant to their existing state-based plans or through CHIPs. And that part is definitely on the table as a very significant issue. Should we, as Kevin noted, have that next event that occurs, heaven forbid that would be, of course, arising this fall or winter. So yeah, it's a big factor in regards to the legal opportunities and access to care when you're talking about some states literally disenrolling so many hundreds of thousands of persons from their Medicaid rolls or Medicaid and CHIPS rolls for sure. It's a great point and one for which raises profound implications, particularly on border cities where sometimes you're seeing patients just cross a state line to get to the best care. Highly problematic at times in relation to disenrollment issues.
Imagine a child in a critical situation who maybe has to be transported via helicopter, and there is a refusal, to supply that helicopter coverage, to cover that helicopter. That family could be billed for a helicopter ride of $35,000 for the critical care transport team. If you're already struggling to maintain your Medicaid coverage and you have a personal bill of $35K, that's a devastating bill. And I've seen that happen during the triple-demic. I think we are going to respect everyone's time. We have time for maybe one more comment. James?
No, I was just going to say what a great point. The catastrophic costs that can arise can be profound. And also that one other factor that we didn't emphasize so much, which is so many persons don't even know they've been disenrolled until they actually need care. They get to the hospital and they're told, you don't have coverage. We're not even notifying you properly. You don't have coverage. That's happening in too many states as well. That lends to its own series of ethical and legal issues for those families involved.
I'm going to let Pat, who contributed by sending me a little preview information about coverage for kids in the territories. There are many people fighting for full Medicaid coverage for kids in our territorial possessions. Thank you for that, Pat. But what waivers are there on blue sky days? I'm not entirely sure I understand fully the question, but what she may mean is for non-disaster situations. There are many waivers that CMS has given that you outlined, but I'm not entirely sure what other waivers there are for non-disaster declaration times.
Yeah, I'd ask Pat if you can just to kind of email me about that. I'd love to answer it, but to be sure, I want to get a little clarification, like Marie's saying, on what you mean by the blue sky days in that respect. So good point, but let's address that if we can, I guess, offline. My email address was available, and to be sure, let me know. I'd be happy to address that separately.
I will point out that to all our PPN friends, a recording of the webinar is available on the web page in 2 business days. And I thank you all for joining us. These often are data-driven and legalistic discussions, but they are in many ways as important as making sure we have enough space, staff, stuff, systems, supplies to care for people during a pandemic or a disaster. We have to have infrastructure of having the funding to do so. And this is what I worry about a lot. And I appreciate my co-presenter, Professor Hodge. I appreciate Kevin allowing us this time, and there'll be more to follow on these topics, as Kevin alluded to. And thank you very much for your participation. Thank you so much. And Regina Yaski says eye-opening, and Regina's a colleague from Region 5. So good to know. Thank you very much, and we'll see you soon.
Great. Thanks, everyone.
Bye-bye.